Welcome viewers, welcome to Medico Virally, and today we are going to discuss about infantile hypertrophic pyloric stenosis. The word infantile means it tells us the age of onset of the disease, and the hypertrophy is the thickening of the muscle. And the pyloric means the part, the pylorus, and the stenosis is narrowing. So this is the main pathogenesis of this disease. Here in the image, the muscle of the pylorus is thickened. Due to this, the food passing channel has been narrowing down. When the food comes through the esophagus into the stomach, it cannot pass forward, and hence it gets accumulated in the stomach. This is the main pathogenesis of this disease. And coming to the etiology is multifactorial. That is, it has many factors which are associated. The first one is trisomy 18, and the second one is trisomy 21. 18, that is Edward, and 21, that is Down syndromes. And the third one is a drug which is associated, that is erythromycin. This drug is given to the children in the first 2 weeks of life who have infections. So if the child has been exposed to this drug in the first 2 weeks of life, this infantile hypertrophic pyloric stenosis, there is a chance of occurring. So why I have highlighted the 4 letters are, these 4 letters tell you the mode of action of the drug in the reverse order. MO, that is motilin, R for receptor, and the H means helper. Helper is nothing but which stimulates, that is agonist. So the mode of action is motilin receptor agonist. So this is the etiology associated with this disease. And the next point is the clinical features. The clinical features usually appear in the 3 to 6 weeks of life after birth. This is a newly occurring symptoms such as non-bilious projectile vomiting. In the starting, I have explained that due to the narrowing of the pylorus, the food gets accumulated in the stomach, and hence there is an emetic action, and it is projectile in nature. And why is it non-bilious? Because the bile juices have not yet mixed with the food particles, and hence it is non-bilious projectile vomiting. And due to this, the baby demands refeeding. So multiple feeds will be demanded by the baby. And the last one is olive lump. This is the main characteristic feature of this disease. So in most of the babies, we can find this kind of olive lump, which is oval in nature, firm, and it is associated as shown in the image with this disease. And this lump is firm and oval in the abdomen. And this is the main clinical features associated. And how do you diagnose this situation? We usually diagnose with the help of ultrasonography. And what is the treatment related to this? So the main definitive treatment stands surgical options, that is pyloromyotomy. The word itself tells you tomy is incision, myo is muscle, and pyloro is pylorus. So incision of the muscle around the pylorus. And I just try to present you the image. This image will explain you there is a small incision which is made near the pylorus, and from this incision the thickened part of the pylorus bulges out and thereby widening the channel of the pylorus, and hence the food passes forward. And the more details of the pyloromyotomy will be discussed in the surgical option in the surgical videos. And regarding this pathology, and this is all you have to know, and the main point is olive lump you have to, in the clinical cases when they present, this disease is mostly associated with the male childs. So a male child presenting to the outpatient department, and his age is about 4 weeks, and he has been he has a non-bilious projectile vomiting, and he demands more feeds, and visually we can find the olive lump sign, and this all is related to this infantile hypertrophic pyloric stenosis. And this is all you have to know. Thank you very much for watching.